So it's my pleasure to bring up Marty Taba next. Marty is one of our family practice docs out of Kailua. She's going to be telling you about the great work that she's been working on in the chronic kidney disease workgroup. Marty?
Right. Thank you. I want to take the opportunity to actually highlight how a work group comes together and what kind of things can happen. I have a little sideline benefit of being the chair of the Quality and Clinical Integration Committee, which charters these work groups, and we'd really like to see more of them that are working to driving down cost, improving quality, and help with integration. So let me tell you a little story. So I started as a chair in March of last year, and in May, the Financial Committee, another one of the standing committees for Hawaii Health Partners, came with two proposals on opportunities that could reduce cost by integrating some clinical on a clinical topic. And one of them was trying to reduce our dialysis patient population and end-stage renal disease. And this actually hit home for me because in med school, I didn't feel like I had a great education on chronic kidney disease. And in 2012, the Contigo guidelines came out, and that was after my time in medical school. So I felt like I needed more clarity myself on how to screen and diagnose patients for chronic kidney disease. And we all know that we don't have too many nephrology specialists on the island. So at that point, I submitted a charter for a clinical work group, which was approved, and I wanted to tell you a little bit about that process. So just to let you know, if you wanted to charter a clinical work group, the purpose is to help develop and promote the use of evidence-based clinical practice within Hawaii Health Partners in order to improve the health of our patients and the quality of the service we provide. Being HHP, we are looking too at some financial or resource management also. Okay, so what we did is in July 2015, we sent out a membership-wide invitation to join us in this chronic kidney disease work group. And I was so privileged and pleased to have these members of the committee stand up and volunteer. And what I love about my committee is that they span a wide breadth of specialties. So we have a few primary care, we have a pediatric nephrologist, we have a retired nephrologist, we have hospital-based physicians, and we actually had a kind of patient advocate as well. We also had some wonderful support folks that did everything from, keep my minutes and put out alerts to help with the EPIC support, and we've really benefited and appreciated all the support we've gotten this year. Kind of alongside of us putting together a work group and formulating what our tasks were going to be for the upcoming year, we started to get information from HMSA that they must have been looking at the same data that HHP was looking at, because they also were driving some initiatives on chronic kidney disease. So first of all, they put together these heat maps that they wanted all the primary care physicians to review that had patients on there with labs that they mined from their historical data that put them in buckets of very high risk, moderate risk kidney disease. And they wanted all primary care to look at that, to highlight and hopefully do some intervention. They also asked our HHP group, or HPH group, I guess, to also help on education as well. And that would actually be part of our contract to help some of our financial goals. So we thought it would be a good opportunity to kind of partner what we are trying to do with achieving the HMSA goals as part of what we did in the committee. So as a result, we had some educational programs, primarily around the prevalence of chronic kidney disease, as well as the availability of the Aloha Kidney Program with Dr. Ramona Wong, which is a free patient education program for chronic kidney disease patients. If you were unable to make the live CME program, we asked you to attend either the virtual program, and there was also a 15-minute online learning module that you can still complete by the end of the year for some credit. We were able to reach 80% of our employed primary care physicians, and appreciate all the support that you guys did in viewing these so that we could meet our HMSA goals. We also had some very wonderful and very sweet specialists, vascular surgery and urology, who were also required to watch this and did this to support us. The next thing we really wanted to do was create a guideline for physicians. So we have some in the back. This is a chronic kidney disease screening management tool. And we thought it would be nice to have something for primary care physicians to use that is at your fingertips for a point of care when you're sitting in front of a patient. I really want to thank Brian Driscoll for pulling it together and making it so pretty. It's very easy to read. We have algorithms, education about screening, diagnosing, and management. So we can co-manage with our specialty colleagues as well as appropriately diagnose, put that on the problem list, so then we can work with hospital, ED, radiology, and other primary care urgent access that collaborate with our patient to avoid further harm of kidneys. We have the guide mailed to all the PCPs, urologists, endocrinologists, as well as up on our website. I will say that we took the bulk of the material from Intermountain with their permission, and they granted us permission to use it, so we didn't start from scratch. But once we had that, as a committee, we pulled that together, massaged it, got local expert opinion, and tried to make it our own and have some local resources and things like that in there. So that was mailed out to everybody, and we have some extras. What we've also done, thanks to Melanie Norgren, is put this up on the dashboard. Our hope is that our primary care physicians will look at a heat map, again with our lab results in Epic, to identify patients they may not have realized were extremely high-risk patients for chronic kidney disease, and anybody who may not have been identified or diagnosed. Look at that again, put it on their problem list so all physicians and care providers are aware. So we are hoping that that work will be done in the next year, and with that we'll have hopefully a team-based approach with patients we know with kidney disease. We now can let our inpatient colleagues know, and they will be able to provide education in the hospital as well as be sensitive to not aggravate the situation they may not even know existed. So who should be screened? Oh, sorry, typo. Just wanted to highlight some of the diagnoses that may be familiar to you, may not be familiar to you, and to see the breadth of patients that may come across your door as specialists, that if you could be sensitive to them having chronic kidney disease. So prescribing NSAIDs for gout or osteoarthritis, of course, chemo patients, being sensitive that we should be screening them for chronic kidney disease, kidney insults, also frequent kidney stones, frequent UTIs, and cardiovascular disease. And so next steps for those who need screening, we're trying to encourage all primary care to screen the high-risk patients with a BMP or CMP, a ACR, which I have to stop right here and thank our EPIC ambulatory care with Jenny Chen, who helped us switch the order that we were all using for microalbumin to the ACR, so it was more appropriate screening for chronic kidney disease, as well as ordering a complete UA. We also are in the works, thanks to Kevin Takezawa, to put in EPIC alert annual kidney function screening, monitoring due, as well as putting in a few immunizations if you're at chronic kidney disease stage 4 that you would want at that point in time. And then we want to continue to promote patient education through EMI, our Aloha Kidney, to help preserve kidney function in our patients. And that's all I have. I do have some polling questions, if you'll get your phones out. Number 1, what is something that our system could do to protect CKD patients? If you'll pick only one, med alerts if ordering a nephrotoxic medicine. if we put CKD on the header of EPIC, if we had CKD education provided in the hospital when they're admitted, guidelines from our vascular colleagues when they would like to meet CKD for patients, or if there's an other, which you can tell me after, send me an email or catch me after. Awesome. Thank you very much. All right. Our second question that we have, and this is more because this is the first time I feel like we tried to not only develop, but then disseminate information to our HHP membership, and wanting to make sure we can do this in the best way possible that will catch your attention, be read, and be utilized. So if we have new guidelines and clinical information, how would you like to receive it? And remember, catch me if you have another idea. I have to admit, I'm one of those people that skips the emails a lot of the time. So, all right. Thank you very much for your attention.